All right, we're going to start. Welcome to Lunchalytics 37. Lunchalytics 37. We have healthcare analytics today. 3 speakers. One of them is actually going to be here. Ivor Cribben is an assistant professor at the U of A. He's going to be talking about a special kind of neural network, the kind that's actually in your head. And then we've got Stafford Dean. I think he's the Chief Analytics Officer of Alberta Health Services. He's going to be dialing in and going to be showing up on the screen. And Marcus Lattinen is the Analytics Lead at the Health Quality Council of Alberta. So we have some heavy hitters today. But before we get going on that, a couple of other quick announcements. How many of you here are here for the very first time to a Lunchalytics event? Excellent, excellent. Okay. Second question, how many of you are students? Students. So a handful, a smattering of students. And how many of you are consumers of analytics? You use analytical results to make decisions in your day job. Okay, okay. And how many of you are creators of reports and such? All right, that's about the rest of you. Okay, and any academics in the house? There they are, hiding right there. Excellent. Okay, so without further ado, I will hand it over to Ivor, and he will tell us all about his research.
Sure. So you're going to press them? Okay. So thank you very much for the introduction and the invitation. So today I'm going to talk about some high-dimensional networks with application to brain imaging data. Okay, so before I get started, I'm going to assume that none of you or very few of you know what brain imaging data looks like. Okay, so what I'm going to talk about today is functional magnetic resonance imaging, or fMRI. Okay. Some of you might have heard of, or might have even gone for, an MRI scan. So an MRI scan, we're interested in the structure of your brain. A functional MRI is we're interested in how your brain functions. Okay? So, like this gentleman here, as in most experiments, they're typically undergrad students. Okay? They're our subjects. So it's a non-invasive technique for studying brain activity. And while the undergrad student is in the scanner, we take a series of brain images as the student or the subject is performing a set of tasks. So these tasks may be being burnt, solving a mathematical puzzle, some financial decision making, okay? Or simply, what I'm going to talk about today, you simply just rest in the scanner, okay? So you just go into the scanner and you're told to rest, think of nothing for 9 minutes. Okay, so not an easy task. So what does this data look like? Well, the way I see it, the way I like to see it is your brain is a large cube, okay? And this large cube divided up into smaller cubes called voxels. So these voxels are typically 2 millimeters or 3 millimeters, okay? And so each brain has typically hundreds of thousands of these voxels. And so for one brain scan, we get a signal within one of these voxels, okay? And then we get another brain scan, we get another signal. So we get a whole experiment of signals. So the way I like to see it is, it's like a high-dimensional time series problem, okay? So we have typically 200 or 300 time points and say hundreds of thousands of time series, okay? And we get a brain image, say, every two seconds or so. So the usual way of analyzing this data, and you might have seen pictures like this before, is you see brains like this, and this indicates which areas of the brains are activated as the subject performs a set of tasks. Okay? So this has been the typical way to analyze data. People now are moving to what's called connectivity studies. And here we're interested in seeing the brain as an integrated system. And we're trying to look at how regions of the brains are communicating with one another as you perform these set of tasks. So we define functional connectivity as the undirected association between 2 or more fMRI time series. So it's just some measure of dependence. So typically what we do is we segregate the brain into several brain regions where we just average the voxel time series. And so this gives us what's called brain region time series. Okay? So a nice simple example is, suppose we have time series from 8 brain regions. Very small example. Okay? So if I asked you to measure some sort of type of dependence for these 8 time series, you would say correlation matrix, precision matrix, or the inverse covariance matrix. Or if we let each time series be represented by a node, we could also estimate an undirected graph, okay, where the edges represent some type of connectivity and the nodes represent your brain region. Okay? So if you're interested in this type of analysis, in looking at the best methods for estimating brain networks, it's kind of cut off here, but you'll see a reference at the end. But we're not going to focus on this today. So you may ask, well, why do we do this? What's the clinical utility of estimating functional connectivity? Well, what people have done is they've collected a group of controls and a group of people with brain disorders such as Alzheimer's, ALS, depression, etc. And they've compared the functional connectivity structure for a set of controls on the people with the brain disorders, okay? To understand the differences between these two populations, and more importantly, the hope is to define some type of biomarker for these diseases, okay? So in the previous studies, we've looked at networks for the whole experiment. And you say, well, hold on a minute. The brain is dynamic, okay? So if we estimate a network for the whole time series, that's simply just an average of all the changing connectivities over the experiment, okay? So what people have been recently looked at is what's called time-varying connectivity, or what people are calling dynamic functional connectivity. How is this integrating changing over the experiment? Okay? So this has led to a large number of new statistical methodology in this area for estimating how the connectivity changes over the experiment. So what people started off with, well, they took these covariance, correlation, or precision matrices, and they combined it with what's called a sliding window. So what does this look like? Well, this looks like the following. So suppose that you have time series from several regions of your brain, and we wanted to understand how the functional connectivity, or the time-varying dependence, if you want to think about it that way, is changing over the experiment. Well, you simply just define a window, you estimate the covariance matrix, you can then move to sparse precision matrices if you want, and then you simply just shift the window in time, and this gives us a nice, simple definition of the changing connectivities between your brain regions. Okay? Now, what's the downside of this? It's simple, it's great, it's computationally easy. The downside is, the definition of this window is important. Too big, you're going to miss the changing connectivities. Too small, and you're not going to get stable estimates. Okay? So we approach it from another point of view, and in particular, we're going to combine sort of 2 areas of statistics. One, change points. We're going to look for change points, and the other is community detection and networks statistics. Okay? So community network, or community detection is, we're trying to find nodes that are closely knitted together that are loosely linked to one another. Now, why am I considering community detection? Well, first of all, we attack this problem just using graphs, but we couldn't think about high-dimensional time series. By thinking about this in a community network statistic allows us to consider a large number of time series, or a large number of brain regions. Okay? So I'm going to simplify the method, and there's no detail here. For all the details, I'll refer you to the papers. Okay? So what our method, which we call network change point detection, or NCPD, does, it finds or detects change points in the community network structure. Okay? So it's a 2-step procedure. So it detects temporal change points in the community network procedure or structure, and then once it finds the change points, it estimates the network structure between each pair of significant change points. Okay? Now, what does this look graphically? Graphically is always good to do. So suppose that you have a large number of time series from your brain. You run an experiment. You're resting in the scan. And suppose that there is a network structure that changes over the experiment. So in this simple example, this is just a simple example, suppose that you have two communities for the first 100 time points. Again, each of these nodes represents a time series. And the membership and the number of communities changes at time points 101 to 200. And then again, just the membership of the communities change at 201 to 300. Okay? So this is just a simple visual display. So what our method does is, it first of all finds where the changes in the community network structure are happening. So it estimates, it's cut off here, new, row, and new. And then between each pair of significant change points, it estimates the network structure there. Okay? So details are referred to the paper. I only have 15 minutes. Okay? So what we did is we ran this on a resting state data set. So again, just to summarize, you're put into a scanner for 9.5 minutes, and you're told to rest. Okay? And we have 45 controls. Okay? And we ran the procedure, and we found significant change points in the community network structure for each subject. So when you look at this, you say, well, some subjects have 3 change points, some subjects have 4, 2, and then there's subject 16. Okay? Subject 16 has no change points. So depending what audience I'm giving this talk to, somebody says, well, that's a business student, that's an art student, or might have fallen asleep, etc. So choose your favorite or the people you most dislike. Okay? So here, what we do is, okay, so subject 1 is 3 change points. This gives rise to a community network structure, so 4 community network structures. Okay? Subject 3 has 4, so this gives rise to 5 community network structures. Again, the nodes represents the brain region, and the color represents what community it belongs to. Okay? So we look at these and go, okay, great. We find change points, we find community network structures. So what? Okay? So what we would like to see is we don't expect the states to be similar at the same time, because it's a resting state experiment. What we do expect to see is, at some point, some similarity across the subjects. So state 3 for subject 3 might be similar to state 1 for subject 1. Okay? So we want to find common functional states or functional modes across the subjects. Okay? So our method allows us to do this, okay? So I'm delving in a little bit deeper. So our metric of change to find the change points was the cosine of the principal angles between subspaces, okay? And here we were looking for the largest difference between these two subspaces. To find a similarity across the subjects, instead of looking for the smallest criterion value, we find the largest criterion value to show us the similarity of the networks. So for example, we are stating that subject 2 partition 2 and subject 20 partition 2 are similar states, and subject 16 partition 1 and subject 30 partition 3 are also similar. And what I mean by similar is the yellow nodes here are similar to the yellow nodes here, the aqua and the pink and the aqua here. And the same over here. We're looking for nodes that are in similar clusters across the two subjects. Okay? Okay, so to revise, to summarize, we have found a method that looks at the community network structure changing over time. This gives us some functional connectivity or functional characteristics of the brain. Well, how can we use this? Okay? Well, we can use this so for my example, we just had a set of controls. What we would like to do then is run it on a set of controls, look at their functional modes, what they have in common, and then do it for the same with people with brain disorders. What do they have common? And more importantly, what's different across these two sets of subjects? Okay? So this will hopefully lead to, biomarkers, diagnostic and prognostic indicators of these disorders. We're a far bit away from that at the moment, but this is where we're leading towards. This example or this methodology obviously is not restricted to brain imaging. If you're interested in how the network structure is changing over time in a time series problem, you can run this. Okay? So if you're interested, there's some R code available on my collaborator's website. And just to give you an idea of runtime, so on my laptop for one subject, which has 285 time points and 116 regions or time series, this took about 2 minutes. Okay, so I only have 15 minutes. I want to give you a broad aspect of what we're doing in neuroimaging. Okay, so that was step one. Step two is, again, I won't have time to go into the details, but we have a set of controls, we have their brain networks, and we have a set of subjects with brain disorders, and we have their brain networks as well. Okay, and we want to know, are there differences between the two? Okay. So for example, you have a set of controls. This is just a simple example. Each of these have 5 brain regions, and there's some sort of connectivity between these 5 brain regions. You have a set of patients, again, the same brain regions, we estimate the connectivity. Are the connectivity or the networks between these set of controls and the set of patients the same? Okay. So how would you do this? How are people doing this at the moment in the literature? Well, they take one edge at a time and test the difference. And then they do that for all possible edges. Okay? Are you testing the network there? Well, you are, but you're doing bivariate tests to do it. So we came up with a method. Again, I don't have time to go through the modeling, but I'll refer you to the paper. We have a method that tests jointly the whole model, or the whole network, okay, that takes into consideration the autocorrelation and, more importantly, the heterogeneity across brains. Our brains are very different. The networks for each of our brains are also very different. So our methodology, as opposed to the individual t-tests, takes into consideration the whole network and also the other sources of variation. So I'm going to skip the details and go to the example. So we ran this method on a study of dyslexia. So again, it was resting state. Okay? So subjects, we had a set of controls and a set of people with dyslexia, and we put them into a scanner and they just rested. Okay? So this gave us 200 time points, and with my collaborators, we focused in on 11 brain regions. Okay? So just only 11 brain regions. And they were chosen from the previous literature. So here we have a display of, so the upper triangle is the average correlation within these brain regions for the control group. And then the lower triangle represents the average correlation for the dyslexic group. So if you look at this, you can see that they're quite similar. Okay? So when we ran our test in it, we found there was no differences between these groups, okay? Which is a negative result, which you always hear journals are very afraid to publish, okay? But we did get this published, okay? So there is hope for us. Okay, so then the last methodology, I know I'm running out of time, that people are beginning to look at now is longitudinal data, okay? So you have a set of controls and a set of subjects, and you not only look at one brain scan from these, but you scan them several times over time, okay? So each subject might be scanned, say, every 6 months or so, okay? And here we're interested in the group differences between the set of controls and patients at baseline, but also their longitudinal trends in the networks, okay? So we're looking at the differences between each of these. So the methodology is on this slide. I'm not going to spend one more second on it. For details of the methodology, I'll refer you to the paper, okay? So what we have is we have data from what's called the ADNI data set. So it's a open source data that's freely available. And we picked 79 images, so 79 scans from 26 patients who had Alzheimer's disease. And then we picked 111 images from 30 patients who are just our controls. And we had 1 to 6 visits for each of the subjects. So here we're looking at age against correlation for pairs of brain regions, okay? So if you just focus in on this, this is a subject with who was scanned 4 times in longitudinal time, and we're looking at the functional connectivity between these two for each of the scans. And then we did that for all subjects for 2 possible pairs. Okay? So as you can see, there's variation across the subjects. Okay? So what we did then is we estimated the main effect. So again, the upper triangle is for the Alzheimer's group, and then the lower triangle is for the control. This is, and then the longitudinal trends, again, the AD group and the CN group. Here is the differences. And then we tested the differences at baseline of the whole network and the longitudinal trend. And we found no differences between the controls and the Alzheimer's at baseline, or no differences in the slope. What we did find, though, there was a significant difference in the local connectivity between the hippocampus and the posterior cingulate, after correcting for multiple comparisons, obviously. So we found local differences, but no global differences between these 2 groups. So in the interest of time, I'll leave you with the references. Thank you for your time.
You have time for 1 question, maybe 2.
Yeah.
Yeah, go ahead.
So when you're looking at those covariance matrices and those people are in a rest state, do you expect that if you did the experiment again, but got them to do a function, like for the dyslexia case, if you ask them to maybe spell something out, do you think that when they're doing the behavior that typically shows that symptom of dyslexia, that you would see different covariance matrices as opposed to you didn't see any difference in the resting state?
So people have, in terms of disease versus controls, people have focused on this resting state data, which as a non-neuroscientist, I find strange. Because if you go into the scanner on different days, and I think this relates to your first part, your resting state will be different depending on how you're feeling that day. Okay? So, I mean, there is commonalities if you scan people on consecutive days, but there are differences. So I would be much more with you. We should focus on task-based fMRI rather than the resting state. There's just too much variability with this resting state. So I focused initially on task-based data and thought this was great, and then noticed that everyone else was working on this resting state. So I've joined the crowd, okay? So do we see differences in this dyslexia data? Not for these particular, but definitely for other people that we've scanned, yes. So I'll refer you to other papers if you're interested.
All right. Okay. Thank you very much, Ivor. That was fantastic. And we look forward to seeing how this feeds into creating the super intelligent brain, because if we can scan our brains to enough detail, then we can recreate them, right? Yeah. So there we go. All right, I knew it. That's one of my pet goals in life. Our next speaker is Stafford Dean with Alberta Health Services. While Dana gets him online, just a quick announcement. We are running Lunchalytics in Calgary. It's actually expanding, and which is kind of ironic because 2 of our speakers today are from Calgary, and that's why they're remoting in. But next Monday, there's a machine learning Lunchalytics going to happen in Calgary. We have these 3 speakers, ATB, Daryl Humphrey, who spoke here on fraud analytics, and Ray Patterson on machine learning in customer service reviews, natural language processing stuff. So if you're interested in those, you can catch them online, live, or you can call your friends and say, go take good notes and show up. So I think we still have a few spaces left in Calgary, and they can RSVP here. All right, do we have Stafford on the line?
Okay, can you guys just do an audio check? Can you hear me?
We can hear you.
Perfect. my screen?
And we can see the screen.
Okay, and I'm getting a bit of an echo, but that's okay.
Yeah.
1 second. Okay, sorry about that. So thanks very much for giving me a chance here. I'll be pretty quick. So I'm Stafford Dean, the Chief Analytics Officer for Alberta Health Services, and I thought I would first just kind of give you a bit of an overview of data and analytics in AHS, and I'll give you maybe a case study here on one of the risk prediction stuff that we're doing. Yeah, I'm still assuming you're all hearing me okay.
Yes.
All right. Okay, I'm not getting anything back. I'm doing an audio check.
We're muted, so he can't hear.
Sorry, we're just on mute here, but we can hear you fine. Thank you.
Yeah, okay, thanks. Okay, so just a little bit here on get rid of that. Sorry. There we go. Just a little bit on, the data and analytics side of healthcare. It's super exciting times for us. I would say we're pretty data starved when it comes to our core business of health clinical service delivery. And, we're looking at the human data ecosystem and how much data it can create. And, we're largely still just in the healthcare encounter data world. And we understand that, the ability to get more and more data is going to really be able to increase our predictive precision in a lot of our models. Especially with precision medicine coming. So, I think we're pretty rudimentary, pretty basic today, but I think the future looks really bright. And I'm having troubles with advancing my slides here, so apologize for that. They're not moving. There we go. Just so you know, we do have a huge physical challenge, as I think as everybody knows, and this is a graph of spending per capita. Age adjusted, adjusted over time. Alberta is the black line. And we're spending significantly more per capita than, how do I get rid of this? There we go, sorry. Than any other province. And, we really need to understand the value we're getting for this additional spend. It's like around $1,200 to $1,300 spending more per person per year than the national average. And we know we've been competing with oil and gas, and there's lots of money coming in through all of that. But, to me, the data and analytics is a key piece to understanding this. And again, I don't know where I can, there we go. Is that, no? How do I advance the slides? They're not responding here, you guys.
Sorry, we just lost your screen there. Oh, you're back.
Yeah. Okay, so just trying to figure out how to advance the slides. There we go. Must be a big delay. So we have massive capacity. We basically have a big data warehouse. We have all kinds of variety in our data. We have many customers, right from frontline clinicians all the way to government and nationally. We have a workforce of 450 strong, lots of them super highly trained. So I think Alberta is lucky in the sense that we do have quite a bit of capacity to this. And it is a hub and spoke structure because it's so big, we embed our analysts right into the business. Oracle database back in our data, our warehouse is really important for us because it really increases our analytics efficiency. As all you know, we spend less time looking for data, and it is secondary in nature, which means we're basically capturing all the data that's created as people interact with the healthcare system. We're taking that data, put it in the warehouse, and using it. We're using it to support outcomes improvement. I won't get into all the data sets, but there's many of them. And it is a distributed system. This is really important. And we allow some autonomy and ability for these areas to come in and bring their own data. Seems to bring analytic products and delivering it to the business. My model is very much empower the analysts, attach them to decision makers, provide access to the data as long as it's compliant with the Health Information Act, and watch them go. And by that philosophy, we've created a ton of content. And we deliver data through Tableau right from the front line. Like it could be as specific as an outcomes management dashboard for pediatric epilepsy, all the way to high-level reporting for the board. And there's a lot of advantages of using Tableau to deliver our analytics. One is we actually have a lot of good visualization in it here, and it's efficient. We can automate it connected to our warehouse. Here's a quick screenshot about when you go in. And I'm going to go in and take a look at some of the actual users here. So the 350 folks are embedded into the business, and they are building stuff. And here I've just got a quick screenshot. That kind of shows over here, you can see where all the people are organized and connected, embedded into the business, all kinds of different areas. And here's the people supporting this and building that. I can go in and look at the content, and because we're pretty open, and said let's attach analysts and decision makers, give them access to data. We actually have an explosion of content. Some of it's updated every year, some every 2 years, some daily, real time. Now our challenge right now is actually report navigation. But I think it's a good problem to have because having the content it wouldn't have been there if we actually didn't empower the analysts to let the data flow. There are a couple real basic ones. This is one for the board and executives. We're always managing or measuring the bed population ratios. How many acute care beds do we have, needs adjusted, and what is the variation? We're also having tableaus and having tableaus and reports on interactions. This is important because this has really gotten rid of a lot of our routine ad hoc data requests, like readmissions is this particular one. And I get so many different variants on what that readmission requests are. I want to buy different ages, or I want to buy different diseases, or I want 7 days instead of 30-day readmission. And so we build these tableaus to deliver the data to the business self-serve. And I'm not going to get in here, but you could interact with it. You could pick just Edmonton or the University of Alberta Hospital or the Foils compared to the university. You could go right in and look at heart failure readmissions or appendectomies and all that. The other nice thing about Tableau is you can actually deliver, or you actually get data on the utilization. So when we kind of purge the mode of using spreadsheets to deliver data and off it goes and you never know what happens to it, we now actually get data. We do analytics on the interactions. What are the most popular dashboards? What kind of people are using dashboards? People like you are using these sorts of dashboards. Do you want to do that? And, it's kind of big brother-ish, but, I can go in and look to see if our CEO, what kind of dashboard she's looking at and those sorts of things. Now, the real important thing is the true analytics. This is a bit of a use case. That was basically the overview, kind of where we're at as an organization. This is more of a use case. And, I would argue that, we're about to spend a whole bunch of money on a clinical EMR. We actually purchased Epic for the folks that aren't close to healthcare. That's basically a computer system that helps clinicians deliver patient care. And the data that's created in these systems is the key data to transformation. It is the data that the front lines, people delivering the care on a real-time basis, see themselves in. It's meaningful in there and all of that. And it's actually one of our biggest data gaps. A lot of the data in healthcare is administrative in nature, i.e. we're using data that's created from paying doctors, for example. We're using data that's created from booking OR. But the real detailed, rich clinical data is actually what's in these clinical information systems. And we're rolling out this clinical information system, and we're getting in there right up front and pulling the data out of the systems the day one. Now, I'm going to give you an example, heart failure. Now, with heart failure, there's lots of evidence that if you do certain things and manage heart failure patients, you should be able to manage readmissions and things the same. There's lots of evidence on the best care. Unfortunately, without a province-wide clinical information system, it's hard to measure whether or not we're following evidence-based care. Now, in this particular one, this is out of the Calgary Rocky View. And what we're doing is we're mining the EMR data. We actually have a risk prediction model here that I'll show you. So what we first do is decide what are our important outcome measures. Here, what we're looking at is length of stay. You know, if we can get these patients out sooner without any adverse events, then we can treat more patients in our hospital system. And also, if we can manage their readmissions and actually do better follow-up in the community and all that, we can reduce them coming back to the system. Heart failure has a 20% readmission rate, which is really high, so lots of opportunity for improvement. So the key here is to link the outcome measures analytically to the process measures that drive those. And that's where the evidence comes in. And so here, I'm going to see if I can move this little thing here. There we go. Here you can see this is the order set. So when they do come in, there's a bunch of things we should do to the patients that are evidence-based. And what we're doing is checking to see the compliance with the order set. Clinicians, are you actually using that when you come in? That's what this one is all about. Again, I apologize, get a little delay here on the slide advance. Anyway, there we go. There's another one. So this is compliance with the order set. Ejection fraction, another important process measure. These folks should have measurements of their heart pumping ability. Also, sodium restriction. Salt's not good for these kind of patients. And the daily weights are over. If their weights fluctuate quickly within a certain period of time, we know we're not managing the heart failure very well. And the lab tests, best evidence lab tests. So what we do is we bring all these together, and what we ask is, are the patients getting the full bundle of evidence-based care? And they're not. And not all the time do they get them, but there's some good clinical contraindications, reasons why they wouldn't get them. But this is right on the unit with the folks, and it helps them make sure and think down about, you know, why didn't we do that? What you want to see is mostly green. And this is an early project where we're trying to standardize the care of evidence-based heart failure care. And over time, we'll monitor to the extent that this becomes more populated. One of the other tools is the risk prediction. This is some logistic regressions, and what we're doing is we're combining a lot of the data we have in our warehouse, which is about 15 years of longitudinal data. And what you can do is I can measure how often they've used the system in the past, how old they are, some socioeconomic risk adjusters, largely administrative in nature, but longitudinal, so up to 15 years. So as long as folks have been living in Alberta, we do have a pretty good history of what's going on. And we also tag them with conditions, so we have databases that will let us understand, you know, who has a whole bunch of conditions like heart failure and COPD and diabetes. So you get this big comorbidity table that we also use for the risk adjustments. Now, what's different about this is we supplement that lagged older warehouse data with real-time clinical data. And we use logistic regressions and stuff. We built the risk prediction model. Pretty basic stuff. Actually, this one here is one of the point systems. You know, sometimes we don't get too sophisticated, and we actually have basic point scoring systems. So if you have this thing, we're going to give you 1 point. If you have COPD, we're going to add 2 points. We'll add them up, and the higher the points, the higher your readmission risk is. And what we want to do here is make sure that the clinicians pay a lot of attention and order the most expensive intense discharge bundle for the highest at risk. And this means pre-arranging the phone call out to the community within 30 days and making sure there is a follow-up and all of that. And not only that, we actually, in the risk prediction model, which is the next slide here, we actually kind of let them know and display to them what was it that triggered the high readmission. Because if you can let them know what it was, then that's going to influence some other clinical things they want to do. And, you know, I think super, super important in the data and analytics world is we can deliver all kinds of analytics, but it needs to be actionable. And we're working with the clinicians to make sure that these are clinically relevant things. And depending on the risk score and what interventions are tagged, they will do other things on top of that. Anyways, I'm going to stop right there. There's a little bit of room for questions. So essentially, to recap, you know, exciting times in data and analytics. The investments in our EMRs are going to create a ton of data. That's going to be the key data to help us transform healthcare in my mind. So the future looks really good. We got a lot of work to do, and there's an infinite number of use cases in healthcare. And I just showed you one use case that happened to be kind of recent and quite applicable. And I'll stop there.
Thanks, Stafford. Any questions? We have time for 1 or 2 or 3. Yeah.
So
you mentioned report navigation. So you mentioned that that was kind of a chief issue. So is this compiled data presentations that are available, but people don't know how to access it, and perhaps don't even know it exists? Is this the problem that you're talking about there with regards to report navigation?
Yeah, so great question. So, you know, this was the kind of principle I established. So, as I mentioned already, you know, let's empower the analysts, task and decision makers, give them access to the data and watch the film. There was a corollary to that, and it was basically in the spirit of the transparency and the desire to become a data-driven, fact-based organization, we need to be very transparent with all the data and analytic products. So everything is completely shareable with all 100,000 employees unless it's patient or provider identifiable. So what the problem this created is, you know, those physician-specific reporting, that's pretty sensitive stuff. That is really only seen by the department heads, for example, where they can look at their clinicians and, you know, have conversations with them. And the data's here for improvement, not for punitive or judgment or anything like that. That's always an important principle. But the rest of the content is out there. And this was really tough for executives to buy into. You know, they said, well, people are going to misinterpret it. They're going to use it against us. They're going to do it. Because it's essentially public, right? And I said, well, that's good, because that's just part of the journey of becoming data literate. People will use it against us, but we can have a chat. So I have so many dashboards being bottom up, and I didn't put a lot of structure on it. I didn't say things had to be blue and this had to look that way. Go to town. And so what we have is huge variety in presentation styles and so much content that a lot of especially my senior people get frustrated. I'm trying to find this and I can't find it. So that's really what I meant by navigation. And we're trying to figure out search engine ways to do this. We're kind of not doing so good on it, but that's one of our big problems. That was a long answer, sorry.
So you said essentially public. As a member of the public, if you wanted to see one of these, is there a way, or is it actually supposed to be just for the employee and it's just more of an accidentally got out?
Yeah, so, you know, my personal position is taxpayers pay for healthcare, and I would share everything, right? And I think legally we have the authority to share. So I think it's fair game for the public to be able to consume the data as long as it doesn't violate the Health Information Act. And what that means is aggregated data where you can point, and we actually have some out there. We did a demonstration project, and I can follow up with folks. And we have gone public with the dashboard, just testing the waters. You know, being in Alberta Health Services, our core business client is not, you know, citizen analysts. Our core client are the patients in the hospitals, and our obligation is to use the data to improve patient care. We really don't have an obligation to share data with the public, but the government does. And so, and in all the data we have, government has access to, of course. So I'm a big believer in citizen analysts and opening up data as long as we protect it, we don't identify people and all that, but we're not there yet. Having said that little link on the public stuff that we had an experiment with.
Okay, one last question.
Hi, so I was wondering if Alberta Health Services partnered with other companies to get data that could better assess patients' risks.
So you're wondering if Alberta Health Services has partnered with other people for what? I didn't quite hear
to get different factors and data from other companies who could get data that Alberta Health Services could not get themselves. So partnering with other companies, possibly getting data that could assess.
Oh, you mean external data and all that kind of stuff?
Third parties. Yes.
And maybe Dan, can you translate? It's all a little garbly on you. I'm not hearing that question.
Yeah, so he's talking about external data sets. Could be anything from marketing data to psychographics.
Oh, yeah. So I go after all kinds of external data sets, not just public ones, but also data sets created in other organizations. So Alberta Health owns some business functions, the ministry part of the health system owns some business functions that create a lot of data, like claims, for example. My example of paying doctors actually creates a lot of data. It tells us how many GP visits there were, what the diagnoses were, and what the amounts paid were. So Alberta Health actually shares that. We get census data, we pull all of that. So yeah, in general, we do all that. There is one big initiative that's being led out of the ministry, And it's trying to bring all the health data together and non-health data and have an efficient data ecosystem where people aren't replicating the data all over the place. So our role being AHS is we create a ton of data, and the big vision is we want to serve up the data we create to a bigger data and analytics ecosystem that's going to serve way more than just Alberta Health Services. It'll serve the Alberta Ministry. It'll serve Alberta Health Services, Health Quality Council. I know Marcus is going to talk next. Also going to serve the universities. We want to open this up and liberate the data for the purposes of creating knowledge. And we're just working through big plans and big things to do that. We actually think Alberta is really well strategically positioned to make data Alberta's next big asset. But there's a lot of risk and governance around that. This is the people's data. We have to make sure they're okay with it. We have to protect it and govern it and use it for only the purposes they want and all that. So that work's going on. Happy to share that. Early days, but pretty big, grandiose visions for sure.
Awesome, thank you.
Great, thanks very much, Stafford. We'll have to cut it off there, but we really appreciate you joining us today remotely. Thanks very much. Our next contestant is Marcus with the Health Quality Council of Alberta. We're still doing some technical hookups to try and get him in here, but a couple quick announcements. I mentioned that next month we're doing hockey analytics. Maybe I didn't mention that. But Hockeylytics is coming back due to popular demand. If you'd love to sponsor that, or you know someone who'd be a great speaker, come talk to me. We do have quite a few potential speakers, but always interested in hearing different perspectives for that. And lastly, is anyone looking for a job in analytics and you do this kind of stuff? You do analytics, you do Tableau, you do regressions, you do neural networks. Raise your hand if you're looking for a job. Man, no one's looking for a job. Oh, okay, we have one person. And if you're a company that has a job position posted or should be posted for this, just give me a wave right now. Any companies hiring analytics positions right now? Maybe. Oh, we have some maybes at the back. Who are you guys with?
Alberta Status of Women.
Alberta Status of Women, okay. I draw your attention to the Lunchalytics website. On the top, there is a something. On the right, oh yeah, there is a job board. You can post things here. We're trying to let this become a bit of a central location for data science and analytics jobs. So you can see there are some positions posted here. Oh, some of them may have closed already, but this is a great place for both find data science jobs and to post them and find quality people. So, do we have Marcus on the line? All right.
Sorry. Yeah. Thank you. And sorry for dealing with IT stuff on my end. This is ridiculous. Anyway, so I just want to talk a bit about the organization and where we're going with the analytics and our vision. And I think that's a good starting point, and then open it up for conversation. I'm just curious, as I can't see everybody online in the room, does everybody know who the HQC is, or would it be helpful to have a bit of an overview of who we are as an organization and our mandate before I get into what we do and why?
I think an overview is already great.
Cool, excellent. So the HQCA is a legislative organization. Our legislation came into being about 2012. And then it explicitly states the purpose and the mandate of our work. And really simply, the way I describe it, or the elevator pitch I give is that the council is mandated to report and monitor the quality and the patient safety of the healthcare system. And specifically, we measure and assess patient safety and health services. We identify best practice. We assist in implementing evaluation activities. And specific to my area of work is work that we do around surveying Albertans on their experience and satisfaction with patient safety and health service quality. And through that mandate, we've actually landed in a number of different areas of work that we do in conjunction with our partners, so Alberta Health Services and Alberta Health. So we do our primary data collection, which is the survey work that we do, as well as our qualitative work around focus groups and patient engagement, family engagement work. And then as well, we work with the administrative data that the province houses, and we use that to provide information to the public through our focus website. That was something I want to show with the group, and as well as through the reporting that we do as well in different sectors. So, is there any questions around the council and how it works and who we are?
No hands gone up here.
No? Okay. Yeah, so it's not a perfect analogy, but how I like to also explain it is you have Alberta Health Services from, who have a mandate to provide acute care. You have the ministry policies and procedures, and then you have a small little mouse between two giant elephants whose role is to comment on what's going on. So, that's easy. So at the HQCA, as I mentioned, there's really a couple streams of work that we do when it comes to analytics. There's first our primary data stuff, which we do via our surveys. And so we currently collect patient experience and family experience information in emergency departments, as well as continuing care. So that includes home care, supported living, and long-term care. We've been in those areas for a number of years, and we report that information back to providers, as well as back up through to the ministry and to age of governments as well. The reason we work in those manners, we know that quality improvement happens at what we call the cold phase, in those front lines, those small clinic areas. But we want to make sure that the information flows up for policy and strategic thinking, so that's why we make sure the information goes to the appropriate places within the ministry or within our health services. The HPCA used to conduct a province-wide satisfaction experience survey, and we stopped doing that. We felt that a large global experience survey around patient experience, though interesting and informative, did provide the actual information that the citizens and our stakeholders desired. And so that's our efforts over the last few years have been develop area-specific surveys. And as such, one of the areas that we're currently working and would like and planning to roll out is our primary patient care experience survey. And that work's been ongoing for about 2 years now. And we are at a point where we've figured out the modality, we have a really sound instrument, and we're just ready to start the recruitment phase, which we hope to begin in April of this year. Any questions around the primary data itself? Oh, okay. So when it comes to the use of secondary data within the health system, we use it in a number of areas. We do use it for our own monitoring, and one of the areas where we publicly reported the information is focus. So if you have access online, you can just type in focus HQCA, and it would take you to a website. Right now, we only have focus on emergency departments online, but what the website offers is a transparent online environment where stakeholders can look at administrative data in conjunction with patient experience data and get an understanding of how, in this case, how the emergency department is operating and its status from the perspective of the patient or the person-centered care model. What we envision is integrating other sectors. We're just finishing off primary care, so we'll link primary care and emergency departments. Future areas where we want to engage in our continuing care, for instance, so home care, long-term care, supported living. We're also looking to incorporate bringing in the acute care sector as well, and then we'll look at specific patient populations. The intent of focus is to fulfill our mandate around monitoring the status of the health system overall. And so what we envision in the future is a site where public, let's call it operations stakeholders as well as government stakeholders, are able to go in and understand how the different sectors leverage each other to drive patient experience, whether in other sectors or within that its own sector. And so what we're really interested in looking at those transitions of care over time, as well as incorporating as well as support services when it comes to the healthcare system as well. Any questions? Sorry, it's really hard. I'm not trying to get. No. Oh, okay. One of the other ways where we've incorporated the patient, or let's call it the administrative data, is the quality improvement efforts that the HQCA conducts within sectors. And specifically, I'm going to mention the work that we are doing in primary care at this point. So we are providing to every family physician in the province, every clinic, as well as every primary care network, a report that talks about and provides information around the panel or the associated panels. So these reports are meant to stimulate self-reflection and focus on areas such as simple demographics, health status of the panels, health service utilization. We look at also the complexity of the patients and their needs when they are engaged with the health system, as well as we provide also information for governance purposes as well. So to help, for instance, the primary care networks fulfill their obligations to the ministry when it comes to reporting. So these panel reports have been, we're now into the 6th iteration of these. They are available at every family physician province. But currently we only have about a third of physicians requesting the report. So we're looking to move that dial to help bring about that culture of data or data-based decision making or evidence-informed decision making. And what we have seen working with the physicians that have been requesting our panels for a number of years is a transition from episodic care to more of a panel management type of role. So they stop thinking about just their minute or visit by visit, day by day operations, and start thinking about what are the services required for their patients overall. Any questions on the panel report? No? All right. So the panel reports that I mentioned have been focused on family physicians, but in the future we're looking to support specialists and non-physician providers as well in understanding the patient panels that they're responsible for and the needs of those patient panels. And we're working with Simpson and others to push that envelope of work. And as we move forward, I think the difficulties we'll be facing is, I think this is the limitation of the administrative data, is the fact that it is meant for record keeping rather than analytical purposes and trying to bridge that. There's been tremendous work, through Stafford and others, Larry Spencer, the ministry, to work around this, but it is currently one of the biggest areas I see in the work that we're doing right now, is trying to make information from the vast amounts of data that we currently have. So I'm just mindful of time, and again, my apologies if I've rushed through my presentation. I'll send the slides after if there's any questions, the links as well. And then feel free to follow up with me. But yeah, is there any questions about anything? I'm happy to open up.
Yeah, go ahead at the back.
I recently did one of the surveys from the Health Quality Council, and I'm just wondering, how do you use information more quality?
Sorry, I can't hear you. I'm always.
I'll speak a little. I recently did one of the phone surveys from the Health Quality Council, and one of the
Sorry, I'm still having a hard time hearing.
I'll repeat the question.
Okay, just finish, but then.
All right, we'll read it.
Oh, I appreciate that.
Okay.
Go ahead.
So I recently did one of the phone surveys, and I was wondering, how do you use the comments that are provided from the ad hoc at the end? Because I think a lot of the experiences that people would speak to would follow the kind of questions you asked, which were very much about each stage rather than in the health system.
So the question was, she's done one of the phone surveys, and she's curious about how the ad hoc comments at the end are incorporated into the results. A lot of that would be outside of the scope of the specific questions that
Absolutely. So we have a qualitative team of analysts, and that's their job and role. And so we embed our, at the ACCA, we embed our qualitative and quantitative researchers in all our work. And so the role of the qualitative researchers are to go through those ad hoc comments, as well as, to support any of our focus groups that we do. But in regards to the survey itself, yeah, they spend the time thematically analyzing it, providing their analytical lens to it, and we incorporate that in all the reporting we do, both at the front line as well as all the way up to the public government stakeholders.
That's a follow-up. I'm just wondering if they consider doing almost a narrative approach in terms of how they share this information with applications. You might not be able to follow a more statistical approach, or just using analytics in terms of telling how someone would experience their time with their health system.
So alongside control types here, so I'm curious if they consider using more narrative approach to consider kind of the full experience. Pretend that may not be something like kind of a persona.
Yeah, that is a fabulous question, and we love to. Reality is that there's capacity and resources, right? So the ACCA is only 30 people strong. Our analytics team is 13 people who are responsible for the entire system, and our qualitative team is only 3 people, and they support all the system, right? So I think that's a fabulous idea. We don't, to be honest, don't have capacity at this moment.
Great, thank you.
All right, we'll cut it off there. Thanks so much for your time and for the presentation. Thank you, everyone who has attended Lunchalytics. We look forward to seeing you in February for Hockey Analytics. And if you happen to be in Calgary on Monday, feel free to join us for the machine learning event in Calgary. All the best.